Hi, everyone. My name is Yu Jin Lee, and I am currently a PGY5 out of 7 at Stanford University. And I completed a 2-year postdoc fellowship in Dr. Rosenthal's lab as part of the clinician scientist training program. And today I'll briefly present our innovative approach to tumor-targeted molecular imaging of head and neck squamous cell carcinoma that has the potential to change our entire current paradigm on staging and surveillance. I have no disclosures. Dr. Rosenthal's lab has focused on using antibody dye bioconjugates to better target head and neck squamous cell carcinoma. And previously, we have studied panitumumab IR dye 800, an imaging agent where we conjugate IR dye 800, a near-infrared fluorescent dye, with panitumumab, which is an antibody targeting EGFR that's overexpressed in head and neck squamous cell carcinoma. So using this drug, PAN-800, we have shown improved evaluation of tumor margins and detection of sentinel nodes, but this has mostly been studied in the intraoperative setting given the limited penetration depth of the fluorescent dye. So given the success of the bioconjugate PAN-800 intraoperatively, we wanted to address the need for tumor-specific imaging in the preoperative setting. This is especially relevant when we encounter patients with incidental lesions on our current standard of care with FDG PET-CT. And for example, in this patient with a T4-N2B oral tongue cancer, we saw these FDG-avid mediastinal nodes that required further intervention prior to coming up with a treatment plan. So given this unmet need in head and neck cancer and based on prior studies in other cancers, we developed a tumor-specific PET radiotracer by conjugating panitumumab with 89 zirconium, which is a radioactive metal that decays by emitting beta rays that are captured on the standard PET scanners that are widely available. We completed a clinical trial studying the systemically administered 89 zirconium panitumumab in 14 patients with head and neck squamous cell carcinoma undergoing surgery. And we showed that 89 zirconium panitumumab is able to detect head and neck squamous cell carcinoma, as shown in this top row, where the primary tongue tumor is visualized on both the FDG and the zirconium PET scans. We also show that zirconium panitumumab is specific for head and neck squamous cell carcinoma. And this is again highlighted in the earlier patient with the mediastinal lymph nodes, where the zirconium PET actually didn't show any signal in this area. And this was consistent with the pathology report from the endobronchial biopsy that this patient had to undergo before coming up with a plan. So from this study, we showed improved specificity to 96% when we combined the FDG and the zirconium panitumumab scans for detecting squamous cell carcinoma. So using this imaging modality, we hope to change the paradigm and staging of head and neck squamous cell carcinoma, where in the current standard of care, we identify incidental lesions. These patients undergo additional imaging, referral to interventional radiology, interventional pulmonology, and basically undergo all these additional visits and additional time before coming up with a treatment plan. And with tumor-targeted imaging, we're able to bypass all of these steps. And similarly, we hope to use this in assessing treatment response and surveillance. So after treatment is complete, most patients undergo post-treatment PET scans, and after about 6 months. And depending on what the scan shows, they might undergo additional imaging or clinic visits until we get final confirmation of whether this is recurrence or response. And using tumor-targeted imaging, we can actually get this anytime because there's no wait period to allow for inflammation or post-surgical changes to stabilize. So we're able to confirm inflammation versus recurrence and versus response immediately. So we're continuing to innovate in this field by studying another radiotracer that has the capability of both preoperative and intraoperative imaging. And in the path towards commercialization, we do face several types of barriers. I think the most important thing will be reimbursement costs as we try to bring this more accessible for all patients. But I'm excited to continue to work on this. And I'd like to thank the Haynes Committee for the opportunity to present my work. And I also like to thank Dr. Rosenthal for his continued mentorship and support for this research project. Thank you.
Well, incredible job, incredible job. I'm so tempted to try to delve into the technology because I am a biomedical engineer and I'm a nanotechnologist, but no, today we're talking about commercialization and moving those things forward. So my first question for you is, of course, you did mention that reimbursement is how you see it being your greatest hurdle, but what are your next steps? Like reimbursement is a little down the line. What are your next critical steps to start to translate this from a strong research technology into something that's going to impact people in the market?
I think the biggest thing that I can personally work on is conducting cost effectiveness studies to actually show what the actual like benefit costs and the benefit to these patients will be based on the study that we have, because now that we have sensitivity and specificity data, we can apply that to what these patients are undergoing and actually put that into a model where we can actually predict what the costs and benefits would be.
Perfect, perfect. And then if you were thinking about, because, you know, if you're going to want to bring this to market, you're almost like a biotech pharma sort of entity, right? So who would be the first people in the market, like in the industry, that you would want to talk to in order to figure out a robust commercialization plan?
Yeah, so I think it's nice because this we can work with people who have already come with current existing tracers that are already available. So the companies that are, or companies making the the FDG PET tracer. There's also a new nerve imaging tracer that's available, and I've actually worked on clinical trials with them at Stanford. So I have a close relationship with them as well. So I think I can continue to work and collaborate with them and learn from their experience.
Ask them open-ended questions, because that will allow you to learn how to chart your pathway in the most efficient way. You know, no need to rebuild bridges that have already been built. So excellent work. Great job.
Thank you.
Love it.